Hello and welcome to an industry-sponsored ASRM webinar, Beyond the Donor Profile. Our panelists will be discussing the importance of obtaining updated medical information on gamete donors. I am Sarah Maya, Digital Learning Lead and Webinar Coordinator at ASRM. This is an industry-sponsored webinar hosted by the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Please note all attendees will be muted except the panelists. Please type a question in the Q&A window at any time. We will read as many selected questions as possible to the panelists. A recording of this webinar will be archived on the ASRM website in the coming weeks, so please watch your email for notifications. I will also drop a link in the chat shortly. Our moderator for today is Lisa. Over to you, Lisa.
Thank you so much, Sarah. I really appreciate everyone being here this afternoon. I know it takes a lot of time and effort to step away from your work and attend this meeting, and we really appreciate it. We are so glad that we are able to talk about such an important topic, and I feel so grateful to Every, which has been very forward-thinking in this concept, and both to them and also Aisha Lewis as the director and president, who's done so much to help advance this industry and her forward-thinking approach. And today I am honored to say that I'm working with other industry leaders to talk about this really fantastic topic, and I will let them introduce themselves. Pamela, can you start?
Great, thank you. I am Pamela Callum. I'm trained as a genetic counselor. I've worked in reproductive genetics for many years, including formerly with California Cryobank and Donor Egg Bank. I am the founder of Tandem Genetics, a telehealth genetic counseling company, and I'm also a consultant for Every, as well as other clinics and laboratories in genetics.
And Melissa?
Hi, I'm Melissa Lindsay. I'm the founder of Donor Conceived Community. I'm a donor conceived adult. I'm part of the late discovery group who did not know they were donor conceived until adulthood, and have just committed to building resources and listening in our community to parents, donor conceived people, donors, and the professionals who work with them. So glad to be here.
Isha.
Hi, I'm Aisha Lewis. I'm the president of Every. I've had the pleasure of working in third-party reproduction for 24 plus years now, and it's an honor to be presenting this very important topic to ASRM.
Wonderful. And I'm Lisa Schumann. I am the founding director of the Center for Family Building. I've been working in this field for almost 30 years now and worked a great deal with ASRM on publishing research. I've worked in-house at some fantastic fertility clinics and also through my group of counselors and therapists. I'm also co-author of a book called Building Your Family, the Complete Guide to Donor Conception, the Building Your Family podcast, and the Building Your Family platform. And I feel very excited to be here and very happy to be part of moving this needle forward and thinking as much as we can about the future of the families that we treat. So these are our disclosures. Next. I will talk a little bit about the goals of this discussion, and then I will talk a little bit about the importance of the mental health perspective. So we want to examine this topic under the lens of the mental health specialist, the genetic counselor, program administrator, and member of the donor conceived community who you've just met. We want to discuss possible ways programs can implement changes, although we won't be talking about it extensively. I will be talking about it, however, at ASRM in my postgraduate course. So if you'd like more information, you can certainly join me there. And we want to encourage further discussion on how we can create better programs to support the needs of all the stakeholders, whether it's inside of your practice or outside of your practice. Next. So let's talk about the changing, our responsibility, the changing landscape. Everything has really changed, as we all know. Many intended parents and donors are requesting ways to receive information about their medical information. We know that it's changed. This industry has changed quite a bit since direct-to-consumer testing has started. We also know that, of course, as all parents know, if the children are concerned, the parents are going to be concerned. So our intended parents and our recipients are going to be very interested increasingly in this information. And we know that this is also moving forward because we see what's happened in Colorado and the recent changes that are likely to happen in other states as well. Next. Now, years ago, in 2014, the Ethics Committee said that donors and programs must recognize that they have a unique and ongoing moral responsibility with each other, as well as with the recipients and their children, and this obligation does not end with the procurement of gametes. Next. And more recently, we've seen this recommendation that it's important to share ongoing information, that all of the people involved in this system that I'll talk about in a moment are important to consider, and that it's important for us to think beyond our medical interventions. Next. So what are people thinking about? So of course, the donor conceived people, as well as their families, are going to be concerned about a lot of things. But two of them that are often cited are consanguinity and medical and emotional information. So, of course, it's underreported. We don't hear a lot about it, but we do hear sometimes, like this woman in Connecticut who talked on CNN about her high school boyfriend, who she found out through genetic testing was, in fact, her half-sibling. And this woman on the right, who was very concerned about not only the number of genetic siblings she had and how distressing that was for her, but also she had a number of medical conditions that she acknowledged may have not been prevented, but at least remediated had she known. In addition to that, the surprise of having these medical conditions was very, very disconcerting and stressful for her. And had she known and had updated medical information, she may have been in a different now. Next. Now, some of you may have remembered this story about this young man who committed suicide. I think this points to a number of issues. One of them, many of you have probably seen recently, our industry is moving towards a much more streamlined and unfortunately sometimes inefficient psychological screening process. So we absolutely need to do that better. But also, it's important to have updated information because we don't know how these difficulties, these mental illnesses, will show themselves over time. There are many mental health conditions such as schizophrenia and bipolar disorder that may not be seen for a very long time. And without that information, we really don't know how to manage our kids. So there are issues besides being able to intervene. We also know that certain medications are contraindicated for certain psychiatric issues. And so we really need to have this information for our future children. Next. Now, sadly, this information, had it been known, could have helped this young man. We discovered later that his donor had schizophrenia and had died of an opioid overdose at the age of 46. This young man died at the age of 27. So this is one example of many that you've probably heard on the news where there are issues that may have been prevented if we had updated medical information. Next. So what we're going to ask you today is to think about something a little bit differently than maybe you've thought about before. I've worked in-house in several fertility clinics, and of course, I understand the feeling of wanting patients to get pregnant and seeing the trouble that they go to try to create their families. And we're very focused on that in this process of helping to create families. However, instead of putting the donor conceived community and everyone who's involved in these social networks kind of in the balcony, I would suggest that we put them in the front row or at least in the orchestra when we're thinking about this play and the interplay of relationships that happen as a result of the matches that we make. We are making matches that will extend for many generations and to many people. And so small decisions that we can make early on can have an enormous impact on the way that people live their lives for many generations. Next. So who are we impacting? All of the stakeholders and all of their families, the donor conceived people, and of course the recipients. And all of these people will be affected. As I said, as any parent knows, we are concerned about our children, and this will impact all of us for many generations. In addition to that, many of you have probably seen an increase in known donations in collaborative relationships. And so we do see that more and more of this is happening, not just with single parents and the LGBTQ population, but with lots of people. And different family methods are going to increase over time. Different family formations are going to be part of our society. And we really need to understand how those relationships work and what medical issues will come up as a result of these relationships being made early on. Next. So to summarize, as we know, anonymity is no longer possible, even though that's the way many of us operate as we work day to day in helping our patients. So we need a perspective shift. We need to understand that donor conception is no longer just a cure for infertility. It is something that we are participating in that will have long-term implications for the future. And so in order to help our future families, we really need follow-up and support for everyone involved. It doesn't necessarily have to be within your clinic, but it has to be somewhere. And today we're going to talk about a few different places where you might be able to find support.
All right. Thank you, Lisa. So now I want to focus on the genetic considerations related to the medical history collection for gamete donors. It is first important to consider the original medical history that is collected from donors. There are very limited regulations regarding what medical history screening for genetic family history purposes needs to be performed on donors. The FDA and New York State have limited regulations regarding medical history and genetic screening. The ASRM guidelines, as you can see here, were recently updated, and they do provide some more specific details as to some of the testing and the extent of family history screening that should be performed, but it is still fairly limited and leaves a lot of room for each practice to decide the degree of screening that they're going to do on donor applicants. It also is voluntary because these are recommendations and guidelines by the professional organization and not regulations that are required by any authorized organization. As far as the genetic testing, the carrier screening is focused on some of the original conditions for which carrier screening was recommended due to their being frequent and common among individuals in the general population, and that includes cystic fibrosis, spinal muscular atrophy, and thalassemias. Fragile X carrier screening is optional, but for oocyte donors, and any enhanced large panethnic carrier screening panels, again, are optional and just indicated for consideration, but these are routinely performed in many cases on other individuals planning pregnancy, and it is appropriate to consider them for the purposes of donor screening as well. For the family medical history assessment, donors should have a 3-generation family history assessed, but the format in which to do that is not specified. Some practices still have donors complete a questionnaire, whereas a pedigree that documents a detailed family medical history can be a more comprehensive approach for evaluating the risks from a donor. These evaluations should be performed by a professional who has board certification in genetics, according to ASRM. And at the upcoming ASRM annual conference, there are some presentations looking at the strength of family history evaluations and whether pedigree and questionnaire are comparable or not. Definitely, there's been some evaluation of this in the past, suggesting that a pedigree is really a stronger tool for this purpose. So the initial medical history collected at the time that the donor applies to the program is really foundational, and is going to impact all of the information received later on when you receive new medical history from the donor or from donor-conceived individuals. That initial medical history sort of sets the stage about the background that new information is being considered in relation to. Donors should be informed that they have a responsibility to provide this updated information. And when additional evaluation is needed, when that information arises, again, a board certified genetics professional is the most appropriate individual to participate in those assessments. So for donor programs or the organizations receiving this updated information, there are several processes that need to be put in place. The organization needs to document the information, assess it, and then determine what notifications, if any, are they doing based on that information. The decision points that come in include how to decide what information indicates an increased risk to donor-conceived individuals. And so the organization has to decide who's going to make that evaluation and how do they discern what information warrants communication and documentation. Do they develop their own criteria? Do they decide to disclose and document everything? Definitely things for consideration for a donor program and what resources they have to do these actions. Then they need to decide, will the information be shared and who will it be shared with? Typically these days, the information is shared with intended parents. In some cases, clinics who received the gametes have been notified in the past. That may not be the desirable party to communicate with, since it can be several years since the intended parents were seen as patients at that facility, and the clinics really have no ongoing relationship with them or even have knowledge about whether a child was born from those pregnancies. The donor program does not know the donor-conceived individuals typically. They do not know who the pediatrician is, who the obstetrician is for those pregnancies, or who's managing the donor-conceived individuals' ongoing care. And so the intended parents are really the best contact in these cases. But the donor program has to determine who's going to do these notifications and who decides when they will be done, because they do take resources on the donor program in order to do this as well. And so that is a big consideration. How is the information going to be distributed? And do the intended parents know how the information is going to be distributed, if at all? Ideally, the intended parents should be prospectively informed about how they're going to receive new information. And it could be as much as the clinic will reach out to you if it discerns that the information could be relevant to the family, or IPs could be informed that it's their responsibility to reach out to the clinic, depending on what's right for that program. The donor program then additionally has to decide whether the donor is eligible to continue in their donor program and how any existing inventory of gametes will be managed. Will they still be available for use? Will they be available for limited intended parents, such as those who've already used that donor and want to complete their family building? Or does the donor program decide that the new information is too concerning and they prefer not to permit access to those gametes at that stage? All of these things and how any potential decisions they may make should really be shared with intended parents prospectively, so that this is always upfront from the donor program about all of their potential management options, and that they could limit access to gametes if they determine that that's right for their program at some point in the future. Now for just a quick example of what new information can look like related to a donor and donor-conceived individuals. This is from a recent case where a child who was conceived from donor oocytes was reportedly diagnosed with neurofibromatosis type 1. NF1 is a genetic condition that can be inherited in a dominant manner, meaning that if a person does have a mutation for this condition, there's a 50% chance that each offspring would inherit that variant. Can be a very significant disorder involving growth of tumors, which may not be malignant, but can certainly be obstructive. We also see some early signs of this condition in skin changes, including development of multiple cafe au lait macules and freckling in the armpits and groin region. When this child was diagnosed, the investigation in this case involved assessment of the biological parent's medical history. The sperm contributor did not have any relevant personal or family history of NF1, and neither did the donor. Her physical exam records were reviewed, and there was no evidence of any skin findings or tumor development or any other symptoms suggestive of NF1. While this condition is usually about 100% penetrant, NF1 is known to have there's multiple reports of cases where either the condition is mosaic in one individual, such as a parent, so it's somatic mosaicism, and they have the variant themselves, but may not be expressing any symptoms. They can also have germline mosaicism, in which the variant is just occurring in the egg or sperm cells, and then they are not expressing symptoms because it's not in their other body tissues. And since the NF1 gene is a large gene, this is mosaicism for this condition has been documented in many cases. And you'll see in this report on the bottom right that we've actually published a case where an NF1 deletion was detected in a mosaic state in a sperm donor in the past. In this case, we are talking about NF1 being diagnosed in an individual conceived from an oocyte donor, so it is a little bit of a different case. And what's important to consider here is that when you are trying to investigate the source of this condition, is it de novo in the child? Could it have been inherited from one of the parents? Something to consider is that since somatic and germline mosaicism are potential causes of this condition, that if you are going to test the parental sample to see if this was an inherited variant, that you may not be able to detect it due to the possibility of mosaicism. So if you go ahead and test the donor using cells from a blood sample, which is what we did with this oocyte donor, well, it is very likely that her result will come back negative, which it did, because she's asymptomatic, but that does not rule out the chance that the variant could have occurred in her oocytes and that she could still have germline mosaicism. So when considering testing, ensuring that you're testing the right source of DNA to get the most informative results is very important. And understanding the limitations of testing on those blood cells is also important for additional counseling for the other recipient families. Ultimately, in this case, all intended parents were informed about the diagnosis in the affected child. They were also informed that testing was performed on the donor, but again, they were informed about the limitations of that testing due to the source of DNA. And that while this result might be reassuring to them that it was not identified to be a mutation inherited from the donor, it doesn't eliminate that risk due to the possibility that she could have other oocytes that carry that variant, just as the biological father could also have genetic variants in his sperm cells that cause that variant or cause the diagnosis. And then the decision was trying to decide whether or not to continue allowing that donor to participate in the program. The donor at that time was no longer continuing to participate anyway, so it was less of a consideration for the donor program. And oocytes were made available to families who'd already used that donor to complete their family building goals. And the risks were reasonably low. The Other recipient families would have the opportunity to know about the information and decide if those risks, low but undefined, were acceptable to them before going forward with other pregnancies. So the donor program decided that it was sort of up to the recipients and their healthcare providers to decide if it was still suitable for their family. Thank you very much. And now we will move on to Melissa's presentation to discuss views from the donor conceived.
Well, I'm happy to share some of the perspective from the donor conceived community. Next slide, please. Why is this topic important to the donor conceived community? Well, one of the most common things that we hear from our peer support groups and from feedback from donor conceived people, which includes early people who have known their whole life that they're donor conceived and people who are part of the late discovery community. One of the main concerns is health disparity, that we are experiencing opportunities or missing opportunities for prevention, for early intervention, to have an accurate diagnosis. There are times when a certain treatment might be overlooked because we don't have the family medical history or we don't have the information from other genetic family members. And so that's one of the issues, is just overall the health disparity. Another aspect for donor conceived people is just the felt loss of control, not having agency over the decisions. We can't act on decisions. We can't know how accurate our decisions are if we don't have the family medical information. And one thing to keep in mind is in both of these cases, the health disparity and the loss of control, it includes the fact that many donor conceived people don't know that they're donor conceived. So they are making decisions based on false information or inaccurate family medical history, not just a lack of accurate family medical history. So there are both elements at play, what we don't know and what we think we know that's false. This leads to issues of health equity because donor conceived people systematically have less information, less access to family medical information compared to the general population of people who are not donor conceived. Donor conceived people also often carry the burden of education. When a donor conceived person does not have a healthcare provider who is familiar with donor conception, the donor conceived person has to understand that they don't have the professional resources, that provider does not have the professional resources or training on these topics. So the donor conceived person has to provide that education of what it means to be donor conceived, what legislation is put in place, what protections are in place, what the guidelines and recommendations are from the professional organizations. They generally just aren't known outside of the reproductive community and third-party reproduction. So that burden is falling on donor conceived people and also on parents and donors as well. And so we see that this topic is just not generally covered in professional groups or associations, in higher education, curriculums, in continuing education. There's not a lot of information for providers on how to interact with donor conceived people to help them when it comes to family medical history. Donor conceived people also carry the burden of record keeping. As you may guess or have experienced yourself, the electronic medical record system is not inclusive to donor conceived people. There's no place to select the unknown status for half the medical history. There's no place to update the number of siblings or half siblings that are either known or not known through donor conception. And so we also see donor conceived people who may have medical history that they've provided and it's not accurate, and then they have trouble getting that inaccurate information out of the system. So decisions could be made by providers based on outdated information. We do think that most of these things are solvable, and so that's helpful. It's just going to take a commitment across multiple disciplines and industries to make that happen. Next slide, please. Let's talk about some possible examples where this might affect a donor conceived person. You can see in this example here, we have a female college student, early 20s. They're experiencing unexplained weight loss, fatigue, and digestive issues. And their parents have provided an updated medical history to the healthcare provider. They've even gone through follow-up questioning based on the symptoms that this college student is experiencing, and have shared and confirmed that there's no history of allergies or colon cancer, autoimmune diseases, Crohn's disease, celiac, irritable bowel syndrome. There's nothing in the family history. And so this has really stumped the doctors. They're not sure what to do. The first 2 typical courses of treatment are not bringing relief, and they are experiencing steady weight loss, hair loss, and other symptoms. So there's no conclusive diagnosis. The condition is worsening. The student drops out of school, cannot maintain, moves back home, and still this is a declining medical condition. After the recommendation of the healthcare provider to not do medical grade genetic testing, but start off with a 23andMe test, this person learns from their parents that they are actually sperm donor conceived. And the parents are under the impression that that wasn't significant information because they were told the donor was in perfect health. And so they didn't believe there was anything to report there, and they didn't knowingly withhold any information from the healthcare provider. They just didn't think it was significant. And the doctor, of course, wouldn't have thought to ask if there was some kind of disconnect in the family medical history being provided. So going back to the previous slide, just considering the burden on the donor conceived person who at the time is facing a really serious medical condition, that donor conceived person got the results of the 23andMe test and then had to contact their parents and try to get the information about what was going on. The next thing they had to do was make contact with the half siblings. They had to request the medical history from the half siblings, where they learned that there were allergies, Crohn's disease, celiac disease in the family. They had to update their healthcare provider to let them know both that they were donor conceived and that they had half siblings with this medical information. They also put in the work with the half siblings to identify the donor, the biological father, and initiated an introduction and requested medical history from the biological father. Keep in mind, this is all happening while they're still experiencing all their symptoms in decline from the condition. They updated the healthcare provider. They learned about some new action steps they could take based on the information from the half siblings, things that had brought them relief, treatments that had worked and not worked. And so they developed a plan to help her recover her health. And this person continued to manage the updates to and from the siblings on how she was doing, on how they were doing. And then about 1.5 years later, after the biological father reported that he didn't have any health conditions, he was able to let this person know that he had been diagnosed with colon cancer and that they were able to get it all. He wasn't going to need any additional treatment, but he was able to provide that significant piece of family medical information, which then changed the course of her own treatment for her condition and also bumped her up on the screening for prevention of colon cancer based on that new information. Next slide. We obviously have stories like this for donor conceived people that are really impactful for our community, but I wanted to also highlight the experience of possible gamete donors and what they might go through if they don't have the opportunity to update their family medical history. So one example is from our community, a sperm donor in their mid-60s. They were recently diagnosed with prostate cancer and they're undergoing treatment. They don't know if all of the people who are made with their gametes know that they're donor conceived. And they're sharing that they know that this can have a genetic factor. And they're wondering how many people are there from their donations? How will they let them know about their condition? They didn't know of a family history of prostate cancer, so it's not shared on the donor profile. And they would like a way to provide that updated information. And so they have paid to join a private registry, a membership in hopes of finding the people made from their gametes. They've attempted to contact the bank to let them know The place where they donated is no longer in business. They've taken a consumer DNA test to hope to connect with donor-conceived people. And they have also initiated introductions to the donor-conceived people they have met and let them know about their updated medical condition. And so that burden is on the donor at that point, as they're going through their cancer treatment. They're wondering how this could impact others. And they're still grateful for the opportunity to help build families. But now they also have this burden of wondering what the other impacts could be. Next slide. So at Donor Conceived Community, we work with donors, intended parents, and donor conceived people. And overall, our experience listening in these communities is that parents need better education about the importance of communicating updated and accurate family medical history. This impacts the lifelong well-being of their child. And if they understand the why of communicating that updated history, we see that there's a lot more willingness to report a birth. There's a lot more willingness to understand which medical updates are significant. And there's a lot more willingness to initiate that conversation. We also need donors to better understand and be educated about the benefits of receiving and giving updated family medical history. They need to know the process for providing updates and why it may matter for themselves, for their family, and for the families that have received their gametes. Donors, parents, and donor-conceived people need better tools and systems for sharing information. It's just not realistic for everybody to have a Google Sheet and share links and try to take a guess at what information is significant to share. And so we need better systems in place for everybody to make it easier for them to share this information. Overall, transparency provides peace of mind for everybody. Even if there's information that's hard to hear, it's helpful for people to be able to take actionable steps to do something with that information. So we need to look beyond just that initial time of choosing and receiving gametes and look at the larger process. Donor-conceived people are often also fertility patients. They're often also parents through donor conception, and they may even also be donors too. So donor-conceived people should be included in this process because we're part of the other parts of family building as well. Next slide. So now I should talk about how we put this in practice.
Thank you, and hello, ASRM community. If you are part of a third-party program, I imagine you're feeling a little bit overwhelmed right now. And I can relate, because when my team and I decided that we wanted to strengthen our programs to support the initiative in getting updated medical information in a regular cadence and a real formalized process, we had a lot of questions and concerns. The next few moments are really just going to be talking about the questions we asked ourselves and our own internal processes and how we can change things to support greater buy-in with the donors and the intended parents. And so hopefully you can use this as a roadmap if you decide to strengthen your own program. Next slide, please. So in turning to intended parents, we feel like it's very, very important to be honest and transparent about our own challenges and limitations in getting even a baseline donor profile. It's difficult, right? The very first thing we say is that this is self-reported. The donor can only report what the donor knows, and the donor may not be privy to the full body of medical history for that family. And so that's something to be aware of. It may also be true, unfortunately, that the donor is purposefully not disclosing information that would make them ineligible to donate. So that's a piece of it. As an industry, we do, I think, an excellent job trying to bring medical professionals to the field, the clinicians who are trained in doing medical history intake, the psychologists who are doing clinical interviews and psychological assessments, and the genetic counselors who are doing the pedigrees. But all of this is still predicated on the fact that this is self-reported. And I think that's important for the intended parents to know. The other thing that they should be made aware of is that the baseline profile is simply a point in time profile. This is the history as we know it today. It's very likely going to evolve as the donor ages, as her family ages. They're going to find out new medical diagnoses that really do need to be shared with the donor conceived so they can action this information. It's really important to me that we have all of our intended parents meet with psychologists so that they can discuss a forward-thinking mindset. How is this going to look being a parent 5 years, 10 years, 15 years down the road when your children have questions and you might not have access to those answers, or your pediatrician has questions and you're not able to get updated information? And I would love to see that happening first, even before donors are selected, because I also think it's very important that intended parents are aware of the various types of donation that's available to them. I mean, we've got de-identified, but we have a lot of open donation options as well. It could be siblings, it could be relatives or friends, it could be a donor who is okay with meeting the intended parents, formalizing a relationship, and having that information exchange on a regular basis. It can also be semi-open or ID release, but it's hard to ask intended parents to make a decision without them knowing all of their options. So having those options available at the beginning is very important. At least it was for our program. And finally, you've heard this before, but we really do need to identify resources and communities that we can point to as our parents actively parent a donor conceived child. Now, they come back with questions they didn't know to ask at the very beginning. And it's our duty to be able to say, great question, let me point you in the right direction. So understanding who those resources are and how they can access those resources are very important. Next slide. Obviously, equally important is education and informed consent for the donor. When we meet a donor for the very first time, one of the things we say is that being a donor is wonderful, and we're very, very thankful for the consideration. But it's also not a transaction that stops at the egg retrieval. It is a lifelong obligation and has lifelong implications. And we really want that donor to hear that message at the very beginning. Because she's honestly navigating lifelong implications, we feel it's important to include her in the decision-making process. So giving her options of the donation types is something that our program has done. The donor gets to drive which type she feels most comfortable with. And next year, it'll be only open donation. Up until this year, it was on the spectrum of open donation and de-identified. But giving her that power to make that decision really did give stronger buy-in. We also allow the donors to have a say as to where their eggs will go. They mutually match to the intended parent. And we've seen over the years with this mutual match system that this really does create relationships, even in ID release, where people don't know each other, have not met each other, but there is a sense of relationship and obligation that the donor upholds. So in these ways, we were able to get stronger buy-in because it's historically difficult to get donors to give updated information. And just like intended parents, we really do need to point to resources that can support the donor long-term. So finding out, maybe even building out the resources that will help them navigate this journey is very important. Next slide, please. So now you know how we tried to get better buy-in with the stakeholders. I'll tell you what we had to do when we changed our internal program. We had to get everybody together in a room and ask some hard questions. So I encourage you to do the same if you're thinking about doing this in your own program. Get your physicians, your psychologists, your genetic counselors, your third-party team together. And the very first thing you should ask is, how do we currently update this information? And is it working? And if it is, fantastic. It wasn't for us. And so the next question is, how should donors update this information? How should they do it? There's a lot of different options that you can consider as a program. you can say, you know what, I only want to be involved in the clinical care, and I'm going to outsource this longer journey to a third-party service, such as ours, but there's a lot like ours. And these services, we're the ones who are navigating, the medical history updates and helping all parties through the journey. You can say, I'd like to create my own internal program, and you're going to task somebody with regularly touching base with the donors and relaying that information to the intended parents or the donor conceived once they reach of age. Or you can say, let's do a hybrid system. I still want to be involved, but I do not have the time and energy to do the medical history updates. And you can outsource this to places like Donor Sibling Registry, or who we use, which is Egg Donor Connect Nexus. And these are phenomenal services because they register the donor, they register the intended parents, and based on your cadence, they will send out a survey to the donor to elicit updated health information. And for our program, that new information flows to everybody at the same time. It goes to the intended parents, it goes to the medical director, it goes to Pamela, our genetics director, and then we try to figure out, do we have to message this? Is there information here that could be concerning so that we can help the intended parents or the donor conceived process this? But the beauty of these third-party services, you can tailor it to whatever works for your program, however you want to share that information. There's some agencies that do only open donations, and the medical history updates are actual contractual obligations. And that works well, but it really works well if the donor is only donated to one family. In an egg banking situation, when you've got maybe 3+ families that could potentially be created from one donation or multiple donations, this might introduce disequity in sharing this information. So just be thoughtful about that, right? Everybody needs to get this information at the same time so they can action it if their intended parents or the donor conceived. And finally, you're going to have a game plan if the donor is not communicative, right? Where do you draw the line? How many times do you try to reach out? What is your game plan here? And how do you inform the intended parent? But you'll want to talk about that. Diving in a little bit deeper, you should be asking yourself, how often should a donor be expected to update this information? And what types of information should they be expected to update? Is it everything they've learned? Hey, I'm 32 years old and I now have high cholesterol. Or do you want to put parameters on what you expect back? This needs to be shared with the donors and the intended parents at the very beginning, setting that expectation, right? Just setting that expectation. You're going to want to ask yourself what information gets shared with the IPs and the donor conceived. You as a program might say, I'm going to share everything that I've received from the donor with the intended parents and the donor conceived. Or you might have a policy that says, I'm going to share only specific bits of information. That needs to be shared as well with the intended parents. And lastly, how? How is the intended parents or the donor conceived going to receive this updated information? Is it via letter? Is it HIPAA compliant email? Are you going to ask them to continually log into your EMR platform? Are you going to use a third-party service, or is someone going to call? All of these questions should be answered, but once you're done with this exercise, you'll have a stronger game plan of how you can go forward. I promise it's not that scary. That's all I have.
That's wonderful. That's wonderful, Aisha. And I think that, we might have a little time. I'd love to get back to Pam to answer some of the genetic questions that people might be wondering about. And by the way, as Aisha is saying, this does not have to be set in stone. You can institute a few different ideas and then change them and then mold them over time. We're all learning, and this is really important for us all to be in this together. So Pamela, do you feel ready to share a little bit of the genetics with us?
Sure, I would be happy to, and apologies to the attendees. It's always good to have your internet provider working in your neighborhood at the time of your webinar. So sorry about that, but happy to go back to some of the slides and just do a quick review for you.
Well, we have a few minutes, so maybe we can do that. Sarah, can you pull up a few of her slides?
What we wanted to talk about, in addition to the initial family history of a donor, that really is foundational to any new information that becomes available from the donor or from donor-conceived persons, because both information from both sources will change over time. And there were several decision points that I wanted to share to help donor programs consider how they're going to manage that information. Certainly somebody in their program or outsourced, however they're managing it, needs to evaluate the information and determine whether there's an increased risk to donor conceived persons and if that information is going to be shared. So very much like Aisha stated, it needs to be clear to recipient families to what information will be shared, in what way and when, and who's going to make those decisions. The question then is, who's also going to distribute that information, and what are all the recipient categories? So there are the intended parents, who are the most likely recipients of that information, certainly because donor programs don't know at what stage those intended parents may be in their reproductive plans. They may have graduated to an obstetrician, may have birthed their children and be with a pediatrician. And so donor programs can't know who the right medical providers are for helping patients with that information at that time. And the recipients can best get that information to the people who can help them with their care at that stage. The donor programs are also going to have to make decisions about what they're going to do with the donor and remaining inventory. Thank you, Sarah, for going through this. Once they have this new information, does it impact that donor's ability to continue in the program? And how will the existing gametes be used at that point? Often, there are still families who are eager to use those gametes, even if there is new medical information available, because they want to finish with their family building goals. But sometimes a program may decide that that information is not appropriate that information restricts use of any additional gametes. We do have an example on the next slide that talks about a recent case in which a child was diagnosed with neurofibromatosis after being born from oocyte donation. And we had to go through that process of making decisions about what the risks are, who the information should go to. And there were some important points to share on that slide regarding the people that are making these evaluations have to be cognizant of not just what the diagnosis is, but the different causes of the molecular mutation, that the mutation can occur in a mosaic manner, meaning that it's only present in some cells of the body in some individuals, which means either biological parent of that child could actually have the mutation themselves, but it is not present in enough quantity so that
I think we're losing her a little bit. Let's see if she comes back on. If not, we can continue. But as we can all see, this is
they're
really
having symptoms themselves or using.
Gotta love
Are you
technical
losing me?
difficulties.
yes. Technology is wonderful when it's working. Okay, well, I think that these points are really, really important, and I urge everyone to look through them as we share the slides. And we have a few questions I see while we're just waiting to see if Pamela can come back. Aisha, there was a question here. What is Every's approach to confirming a mutual match on a frozen donation?
It's a great question. So the intended parents get to see the donor's profile and the types of donations that she said that she would be interested in potentially moving forward with. And if they say, I like this donor and I'd like to use a cohort more of her eggs, they will fill out a profile themselves. It's as much or as little information, non-identifying at this point, as they would like. Sometimes it's just, this is why your profile resonated with me. And other times I get 7 pages back of, why they really, really love the donor and this is their family and they really want to make a connection. That is given to the donor. The donor is given the opportunity up to 5 days to make a decision as to whether or not they feel comfortable moving forward with this specific match based on this specific type. So the intended parent profile will also say, I'm interested in a fully known donation cycle using these eggs. And from there, once we've got agreement, we move ahead with a meeting and legal contracts. And that's our approach.
That's great. And what about this question about only open? You said next year only open is, what are you referring? It says, are you referring to
Well,
Colorado?
up until now, we've allowed everybody to have a choice, even with de-identified. But we've decided as an organization that really we want to just be an open donation organization. And so it can be ID release, semi-open, fully open. Those would be the spectrums, but de-identified donors would be referred to other organizations.
Great. And then we have another a compliment. Thank you so much for your presentation. And where do the genetic history and screening guidelines overlap for you with the mental health screening guideline and other guidelines? For example, would donors who have ADD or ADHD or depression history and donors with psychiatric issues, how would those genetic counselors and mental health professionals work better together to make those decisions for the mutual match?
Well, that's a great question for you, Lisa. I mean, I can tell you from our perspective, if any professional, genetic counselor or mental health professional has a concern, we usually just stop, right? But I do think there's opportunity to have a stronger connectivity. I can absolutely see situations where our genetic counselors are speaking to, the psychologists to try to get better understanding. I hope I answered that question, but I think it's a great question for Lisa and Pamela, actually. Is there a need to have that connectivity?
Yeah, well, I think that as we move more towards this mutual matching, we will probably have more patients who are open to other issues that the donors might have. If they really like a donor and the donor says, I have some ADD or dyslexia, and maybe the attended parents feel that that's comfortable for them, maybe they would feel more comfortable moving forward with that donor. And we have more of an opportunity for a mutual match process, I think. So that would be my perspective. Pamela, are you free to answer that question as well?
I am here. Sorry about that. I do
Okay.
think that it is just collaborative. We have to work together to understand the entire family history, what the contributing factors may be, and figure out what's best for the donor conceived persons to help determine that if that donor is eligible for the program.
Mhm. Okay. And then here's a question from Melissa. I'm curious about your thought on two topics: how the DCP and adoption communities are related or learning from each other, and how DCP concerns are unique. Number two, while donor banks are absolutely must continue to revise, update, and improve our practices and policies, it often feels frustrating because at some point there's only so much we can do if a parent refuses to disclose to their child that they are donor conceived. What is the DCP community doing, and how can we help advocate / push parents to share this information? Not an easy one.
There are lots of questions built in there, so I'll do my best. So to answer the first part of it, about the similarities and overlaps with the adoptee community, I think it's really interesting to look at what happened in the adoption community, where at one point it was considered best practice to wait to disclose adoption, that there was some idea of preserving normal for the child and then tell them after they've made it through their tumultuous teenage years, and that it wouldn't matter. They don't need to know, as long as they're loved and part of a family, that they don't need to know the information. And that at one point was normal in the adoption community. And then through research and experiences and adoptees speaking out and parents speaking out and birth parents speaking out, the industry really changed to the expectation is for early disclosure, early discussion, And parents were equipped with tools and resources to have those conversations. So part of the process of adoption was acknowledging that there would be a process of disclosing, a process of discussion, a process of helping a child understand across their developmental stages what adoption was, and really a trend towards we don't want a surprise to be revealed at any point. This is information that the child should always know. So we know from those spaces, even though donor conception and adoption is different, that the experience of not having a surprise is ideal, and that disclosure doesn't remove every inconvenience or hardship of adoption, and disclosure may not erase every inconvenience and challenge with being donor conceived, but that's a baseline that parents can aim for early disclosure, discussion, and early and often having those discussions. We also would say that the research, it doesn't all transfer over perfectly, but we can see some ways of discussing adoption that can be helpful to transfer over to ways of discussing donor conception. Adoption is not a cure for infertility, and we can learn from that donor conception is not a cure for infertility either. The expectation to disclose and discuss, I think, is probably one of the best things we can borrow from what we've learned from adoptees. I'd say that a big difference for donor conceived people and adoptees is, one, the full awareness that there's a whole industry around third-party family building and donor conception, and the amount of donor conceived people can see the industry reports of, here's the volume of dollars in the industry, here's the trend to how it's growing, and here's the trend towards different technological advances and AI. It's challenging to see it discussed that way when there are implications that aren't solved for yet for how it impacts donor conceived people. And I would say there's more awareness in talking about the challenges of for adoptees, while the experiences of donor conceived people are sometimes still on the back burner compared to the growth opportunities in the industry. And most of the times that we hear about legislation, it's still for the parents and not for donor conceived people. The other challenge is just the volume. You don't see many adoptees that have 100 half siblings that they don't have stories to go with. You don't see the age gap of, I may have siblings for the next 10, 20, 30, 40 years. And so that's a difference for adoptees versus donor conceived people.
That's great. That's great. So I just wanted to, we only have a few minutes to wrap up, but I wanted to address this last question, Aisha, about the role of compensation and donors becoming forthcoming, and how you feel about that.
That's another webinar.
Yeah.
That's another webinar. You know, that we are asking quite a lot of our donors, especially with this lifelong obligation. So if we were couching compensation under the, okay, we're compensating for the time and the effort and the lifelong obligation that you absolutely have to be involved in, then as an ethicist, I think there's an ethical standpoint that you can make there. However, compensation is part of our landscape, and we know that donors are interested in being compensated. So I understand that we currently have to compensate. I also understand other countries that have decreased compensation have faced massive shortages in having donors. And so we're trying to balance here. I don't have all the answers on this. I really don't. I invite a very vigorous debate on this. I think a lot of very cool industry professionals have a lot to say on it. And I think that would be a great webinar for ASRM to put on at a later date.
I agree. I absolutely agree. And I can say, just from my own personal experience, opening a open donor program within a fertility clinic, I did see a big shift in the donors' experience when they went through fertility treatment or they went through the egg retrievals. They felt very warmly about their process, but when they actually were able to contact or see the faces of the people who they donated to, all of a sudden it gave them a greater meaning and they felt so much more invested in the process. So I do think that it is, as Aisha's saying, this is a really important lifelong decision. And I think, as she's saying, and as Every has done so well, really committed, as the donors will, if they're connected, to being involved for the long term. And I think that everybody involved is willing to help. And we're certainly all, I can speak for everyone, even Pamela, who's not here and unfortunately can't rejoin. But I think I can speak to everyone in saying that we really appreciate you all here, because that is a signal to us that you're also really interested in discussing this. So we're going to wrap up, but I want to thank everyone for being here and remind you that you can see Pamela's wonderful slides on the recorded version. And I hope you come back anytime. You can find us all on ASRM. We're all members of ASRM if you have any further questions.
And the recording will be available in the coming weeks on the ASRM website. And the link looks like ASRM Academy, Academy on the Go, the industry webinars. And so you'll look for this date and it'll be available in the recording there.